Sharon Hospital. Tonight we have Christine McCullough, our Chief Nursing Officer, and Dr. Mark Marshall, who's our PMA, or Vice President of Medical Affairs. We want to keep this as informal and as open as possible. So if you'd like us to give any information as background before we start, or as we get started, it's fine. Otherwise, I want to leave it open for questions. And I want to keep this as an open dialogue. And keep going. Okay. So thank you. Any questions? Concerns? Updates from when we made our announcement from the last time? So when we made our announcement in September, we announced that we are looking at transforming Sharon Hospital. And that transformation involved multiple parts. One, build primary care. We heard loud and clear from our consultants, from our own internal analysis, and from our doctors and the staff that we're short, and all the data corroborated that. So we've been working on partnering with local federally qualified health center from Torrington. And today was the first day where we actually had a dry run and a soft opening of the bedding in their local mobile medical unit, which will be parked outside our hospital for 2 days a week from here on out. And eventually we'll be starting an in-hospital outpatient clinic where they can utilize all of the specialists in the area, utilize our lab, utilize quick turnaround for X-ray and all the other services there. So make it one-stop shopping. And at the same time, by partnering with them, it makes it a little easier to improve our chances of recruitment, which is difficult in rural areas. So we're really excited that we can go in that direction. We're also working on other avenues for recruitment, and as questions come out, I'll go over a little bit of details. The second aspect is grow our other wraparound services due to our demographics in the area. And those include using and improving our internal medicine, with hypertension management, cardiovascular disease, pulmonary, oncology services, I mentioned cardiovascular neurosciences, so neurology, specialists we haven't had in years. And it'll start small with telemedicine, and gradually as the utilization increases and as the specialists are recruited into the system, we'll start having the ability to have face-to-face visits here. We have to start small because we, as a system, have limited specialists in certain areas in areas. Another area of growth is our behavioral health. We have one of the better and best senior behavioral health units, one of the few in the state of Connecticut. And we have potentially have a 20 to 30 patient backlog to have them admitted to our area. And the only thing limiting us has been the ability for staffing and maintaining staffing. In the year of the Great Resignation, we've had a lot of issues with that. We've had to cap those patients in the use of only 12 to 13 beds of our 16 bed unit. So we want to grow in that area and explore looking at autism along the spectrum of adolescent all the way through adult autism, since that all fits in our senior behavioral health area. So we're really excited about that kind of growth. At the same time, since we're only using about 40% of our facility, we're looking at reconfiguring what the hospital is configured like inside. And therefore, consolidating units, consolidating and moving certain services from certain parts of the hospital to other areas to better have areas closer together and therefore make it flow a little bit more natural, particularly for people that have difficulty getting around and people that are having problems, particularly cardiac issues. So we're looking at possibly bringing all that to the first floor and reconfiguring that area. We're also looking at adding and reconfiguring our schedule, and it's more of the ability of expanding our outpatient service reach. And that's important because right now we're limited based upon the number of cases that are actually being done at any time, and the difficulty with long-term maintenance of anesthesia. As we retool the hospital more toward an outpatient basis, we have the ability through the ORs of expanding the services during the day, keeping services on a basis based upon our work groups that we're working with our doctors and the nurses and listening to what they have to say in regards to how many hours should we be available on weekends, and then in the long run what other services do we offer for OR, because we are expanding with GI, orthopedics, general surgery itself, and pain. And that's one area that we lost a very prominent provider just about a year and a half ago when there were issues with the anesthesia. So we're excited about that. Now, to make all that growth and to actually improve our Wi-Fi and to improve our technology within the hospital itself to make us more usable for the future, and we have to pay for it in some way. And based upon the demographics, we've had a lot of issue with maintaining the labor and delivery service. And that is the one area that we are looking to phase out. And so as you see, everything is growth up until this area where we're talking about lack of growth or actually loss. And that's the problem that we have with the labor and delivery. It has nothing to do with quality. It has nothing to do with us mandating certain issues or non-issues. It has everything to do with trying to maintain adequate staffing for less than 200 births per year. Or if you look at the data, we're paying for 24/7 coverage for OB call at night, general surgery at night, anesthesia at 24/7, full-term staff in the unit, even if we don't have anybody in the unit, we have to pay for minimum staffing there just to be ready, just in case. Pediatrics on call 24/7, and anesthesia on call 24/7. So by doing all of that, we have to pay for less than 3 deliveries a week. That's our problem, and that was a difficult decision to come through it, and it was one that we did not take lightly. We feel proud of being able to work and help families build throughout the area and be part of this region as it grows. But at the same time, it's been difficult to maintain the service where it's been tenuous just over the years, and even now it's extremely tenuous. We're looking at an 8 to 10 month phase out based upon our announcement in September, and that's contingent upon if we can maintain staffing. The difficulty with staff, people have resigned, and if it gets to the point where we can't safely staff the unit, then that unit must shut down sooner than 8 to 10 months. And again, it's all about quality of care. So that's kind of where our background is for today. And I leave the floor open for questions and concerns that people should have.
You've made these points several times at the several meetings that you have headed recently, but you haven't really answered the questions that were raised, at least not satisfactorily. Like, first of all, when you took over from Health West, you took over Eric Kahn, which said that the maternity unit would not be shut for 5 years. So you are in contempt of that, apparently. Apparently, you're not filed for another comment, and it seems to me that what you're doing is making it impossible to staff the maternity unit because you're not making a future for people that would want to work there. I've been around for almost 50 years in Sharon, and when I came to Sharon, the hospital was a prime position. There were doctors who came from New York and Boston and elsewhere to work there, and I don't believe that no doctors today want to bring their families up in places like this. I think that you are starving a unit that maybe doesn't make any money. Maybe that's just true of maternity units, but you can make money in other ways and still keep feeding the unit that is bringing in more population here to give you more old people to take care of. So that's
and in regards to the CON, I can answer that in that when that came out, and we will have a forum actually in December by law, by the way the terms of the certificate of need. Twice per year, an outside auditor comes in that audits the agreement if we are in compliance with that or not. And we have been throughout. And part of that CON, in the way it's worded, is that we would maintain services for 5 years if commercially reasonable. And that's been the issue that we have. It's been difficult to maintain.
Perhaps you're going about making it commercially viable in the wrong way. Perhaps you're not doing it in a way that would make it viable. Perhaps it would be better to spend money. And I thought you were not-for-profit. So a not-for-profit company doesn't have to make a profit in every line of business. Surely.
I agree. And over the past 3 years, our hospital has lost $39.8 million.
Good. I hope it was well spent.
So, and that's our profit. And that we have one unit, which actually is a large chunk of that money. And that's, we have to be able to be here in the long run to be sustainable and viable to care for people who will be here in the future.
You're not going to be viable if someone stopped being born here and wanting to come back here. As you heard on the Ween 2 days ago, that is what makes this town, what gives it its heart. It's beating heart. And what you're going to do is take care of the old people, see them out, as I expect you'll see me out. And that'll be the end of Sharon Hospital. I don't see a future for it in what you're planning.
I understand. And everyone's entitled to their opinion and to, or no, just told them why they have this dialogue tonight. So, thank you.
I have always been discouraged about the plans for recruiters. Help us and
David, we can't hear you.
the solution with the plans for recruitment. Help us, predecessor, have expanded those plans to in primary care, expanded things, and nothing's been done. There were 5 primary care doctors here that have come and went. My son, I hear they're not treated very well. The ones that left over, I'm not treated very well either. So I don't think your plans for recruiting primary care physicians are very legitimate. And I think that's going to for the demise of the hospital. Furthermore, we expect people to come to these clinics, the parking garage, you've got millionaires up there. This is a wealthy affluent community. They don't want telemedicine. They don't want to have private clinic. They want a doctor. You have to recruit doctors. And I think it's very, very negative. You have practices in neurology, urology, and it's going in the way because those doctors are not very good. You have to talk about fixing their plate, telemedicine in their place. You just have to get the doctors here. So I think the recruitment model is bogus. Nobody wants to work for us, for Lubex. I don't know why you can't have other models. I mean, for instance, in the past, the GYN people have had salary guaranteed. Why couldn't, for instance, if I was to bring a partner and guarantee half the salary for 2 years or whatever? So you have other doctors out there that are part of Lubex. They give you a choice. Not have to go to a nurse practitioner that's overworked, or doctor that's overworked. There's so many shortcomings in their plans. And it rolls out that preconceived idea that it's not pretty. This is going to look good by doing this, 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 and this. And you have to really look at that track record and show that you're doing these things. So I think it's not having with an answer. So it's good about the time.
Sure. Since we made the announcement in September, we hired 2 full-time nurse practitioners that have started in local practices. So, and we've already interviewed 2 other people to come on board. And one of the reasons we are partnering with FQHC is that they actually have received federal designation as what we call HPSA, Healthcare Professional Shortage Area. So they have that designation, which allows foreign medical grads who are completing their residencies to actually avoid having to go back to their country of origin when their training visa is ended. And then having to wait 6 months to 2 years to come back. By us having this HPSA designation, working with the FQHC, you can have another option to recruit people immediately. We saw this occurring years ago when we designed the medical residencies that on the New York side, which started in 2019. We started family medicine, internal medicine, general surgery, OB/GYN, emergency medicine, and even neurology. And by having those residencies, those were areas of shortage that we had noted early on. And now this is beginning with the 3rd year of those residencies. a lot of the residents, when they first started, as they started, were actually foreign medical grads, because new residencies, American grads, tend to look at it narrowly as you start. But now that we're reaching that point of senior residence, they actually are now prime time to be recruited. And we've already, as a system, hired 2 of those people in family medicine to come into our system. And there's 2 more that are actively looking at this position right now. And it's because of the HBSA that we're looking at. Now, will there be missteps or difficulties in getting people here? Sure, because a third of the job is getting them to come here. Another third of the job is actually having a place for them that they want to stay and live and grow, etc. And that's why we're working with our board members. We're also trying to work with our foundation and other members of our community to maintain and keep them here. And the third one is to have them thrive as a family. So the 3 parts of getting them here. And where we've had issues in the past, and there are a lot of rural hospitals that had issues in the past, is having people stay once they're here or once their guarantee is up when they first start their jobs. Because usually they'll stay for the first terms of their contract and then pay off that debt or their obligation that they have, and then they leave. And that's our job, is to see if we can maintain and get beyond that. And that's why we are working with our board. We've already discussed this with the Foundation for Community Health. We've discussed this with a lot of people trying to retool problems that rural healthcare and rural areas have in maintaining people who come. So it's a multidisciplinary approach, and it's a multifactorial problem, and it's not going to be solved overnight. But we are working on making this area an area that people want to come to train and actually practice in the long run.
It's an area that people love, because that's something that changes up here, the city and so forth. The schools, the ER, etc. expanding. So we want to come here and some doctors. You know, a doctor can be a doctor for 40 years, we recruited. We got some good, damn good people here, I believe people. You know, and then you have people that work with you for a few years, they don't leave. They work for another healthcare system. And that means eyebrows go up. Why would they leave your system and work for another system? They still stay here. We're trying to do that. It's not have good education for doctors. I mean, I'm not just trying to over it and fix it.
Well, I have to say, New Vance is living together here for 10 years. So we are in the midst of it growing, and we as a young system are learning how to deal with the varied aspects of the populations we care for, so we can actually offer the best care to all the areas that we offer services to in the 7 regions where we have hospitals.
That sounds very good, but why then don't you give this area what it wants? And many people come up to tell you they don't want to use the maternity. So does all of your practice have to make money? I thought they were not for profit. What about supporting an area that is essential to ongoing life in the northwest corner of Connecticut and Massachusetts and New York? And lose money. Okay.
Understood. Our health system, and here, this community would love, if we could actually bring in money to the hospital, we would love, actually, in the long run, to have that money returned to the community. That's what a nonprofit is, correct? So we want that money pumped back into the community so it will thrive. So in the 3 years, or 2 years since New Vance has been together, and in the 4 years since Sharon, 4.5 years since Sharon has been purchased by HealthQuest and has absorbed into New Vance Health. As I mentioned, the hospital has lost, close to $40 million. So that money didn't come from here to keep that hospital afloat. If this hospital was a part of that health system, the hospital wouldn't be here today. It would be closed. Let me finish. And on top of that, the communities that actually got money that came from our hospitals such as Northern Dutchess and Rhinebeck, Bassett Brothers in Poughkeepsie, and that profit that those hospitals have brought in over the years actually has not been borne back to those communities because they've been here subsidizing the hospital to keep things working. And that just is not a sustainable model in the long run. That's why we have to make some difficult decisions.
Excuse me, but before your time, there was a pot of money that Sharon Hospital had the use of, and when it was sold to HealthQuest, to Essence, that money went elsewhere. I don't know where it went. I didn't follow the money. but I'd like to know where it went and where it is now. Hasn't been spent on the hospital here.
I understand, but there's a reason why this hospital has had 4 owners in 12 years. We can't keep recreating the past. We have to move forward as we go forward, because that's why all these solutions have failed. And that's all we're trying to do. What we're trying to offer is to offer the best of care and balance the level of high quality care to a community that is changing in regards to the demographics. Absolutely.
I don't think the community is happy with what they're offering. Don't you want the community to be supported?
I understand.
I mean,
Sure.
you go here, you saw people on the green.
No, and we understand that. We also know the hospital serves over 30 communities in the region, on the New York side and on the Connecticut side, all the way up almost to the Massachusetts border.
And people from the New York side and the Massachusetts side came to your meeting, which I watched on Zoom. So this was just a bunch of people who were here and had access to the open meeting, but there's not a lot of people that would prefer to have Sharon Hospital alive and healthy, and having a maternity system that loses money.
No, I understand. It's more than money. It's the whole process of that practice and the ability for that service to maintain itself. It's just is not self-sustaining for us any further. And that's been our issue. I know this is difficult, and we knew this was going to be a touch point. But at the same time, we know that for all the other growth and services that we need and the areas we have to work on, that we have to move on with those other services. So I'm sorry about that, and that's why we are working very diligently with our local obstetricians, and as we, because it is a private decision between mothers to be and the physicians on where those people would be, delivering in the future. And we would love to help them both prenatal and postnatal, which we would be able to work with her in regards to that service where there's liver and difficult, and it will remain difficult, and you don't see any light at the end of that tunnel.
Sorry, I think it's difficult because you let them know, the staff, that you were planning to close it, and naturally they don't want to stay around, they've got to go find a real job that gives them a future. So how can you, on the one hand, say we're losing money, and on the other hand, make it necessary for them to leave to find other jobs? And then you have the excuse, oh, well, we don't have the staff. What happened to the people who were hired and left, chose to leave?
We know, and over the last year or so, nationally, we've had over 20% of the workforce for all medical areas have resigned or quit. Our system is running at 18.8%. That's the national statistic. Currently in our system, we have close to 1,700 openings, and most recently we only had somewhere in the mid-50s the number of applicants for those 1,650 positions. That's the reality of where we live today, and that's what's different than earlier before. There's always been a shortage in nursing in the United States, a relative shortage, and now we're at the point where multiple areas are short simultaneously, and that's why this has been very difficult, and we came to that. So I understand that, and that's why it's difficult to bring in more staff, new staff at this point, because there are no staff to be had.
But I can add that prior to the announcement of the transformational plan, our maternity unit was essentially fully staffed. We had hired over the last 2 years 5 nurse residents. We opened an OB residency program, which is new to nursing. It mirrors kind of what we do for doctors that are learning. It's an enhanced educational program for nurses. And we started an OB-specific residency at Sharon back in, I think, 2019. We did hire and train 5 new nurses, in addition to some experienced nurses that did come on board. We were essentially fully staffed. We had a couple of agency travel nurses that we bring in, and that was really, I think, related to this critical national shortage of nurses, not the transformational plan, because that was later announced. When we announced this transformational plan, obviously, our staff was at the front of our concerns. This is life-changing for the staff that work on OB, and we value them. They're excellent clinicians. We supported them as we announced this, met with everyone multiple times in group settings and individually, and announced that our plan was to phase out the unit over a period of 8 to 12 months, and we chose that time frame from learning from other rural hospitals that have recently closed their OB units, and also considering our expected mothers in the community that we're expecting to deliver at Sharon Hospital. The reality is that, even though we did offer incentive packages and offer to support the staff and find them positions that suit their needs in whatever, community or hospital, if they wanted to stay in OB, we offered that support. But the reality is some staff have chosen and may choose before the 8 to 12 months to go elsewhere. We understand that. We know that they have personal decisions. It's not an excuse for closing the unit. It's just the reality. And we have to have contingency plans in place despite all our efforts and our staff do choose to leave before the 8 to 12 months time period. That's what we've seen a little bit of. We have had some staff decide to leave. We have, as I said, a contingency plan in place. We've brought in more additional agency locum staff. It wouldn't be fair to bring in any full-time staff. We wouldn't get any full-time staff with the plan to phase out the unit. But there is a reality that more staff leave at a rapid rate. We may have to expedite the plan to phase out labor and delivery.
And what about the people in the ICU and elsewhere in the hospital? Their staff shortages elsewhere.
We have staff.
Is there even the other second plan because we have to say the same thing about other units in the hospital?
Can you repeat that last part? I'm sorry.
If we're about the staff in other units in the hospital, the ICU is not necessarily
Yeah.
short staff there.
Yep.
There are many people in the ICU because you don't have adequate staff because they still have right now the wall too, they're jumping ship.
I will say that we have had some ICU staff. So first of all, as Dr. Harper described it, this is the year of the Great Resignation, right? It's not unique to Sharon, it's not unique to OB, not unique to New Vance. It is nationwide. And I personally know this. I sit on many work groups across both states of Connecticut and New York with other leaders across the hospital. Everyone is experiencing the same thing that we are experiencing at Sharon. It's a very challenging climate right now for staff and for nurses. We did have some of our ICU nurses decide to leave. To my knowledge, it is not related to the transformational plan. There are other decisions in their personal life that have impacted their decision to leave. But we have met with all of the ICU nurses. Our ICU nurses are critical to our plan to consolidate our inpatient units. We know that because we are going to increase the level of care that's provided on our med-surg unit in order to consolidate and create what we call acuity adaptable beds. So they're critical in that. And we have met with them. We do have plans to incentivize that staff to stay. However, there are personal choices that are being made outside of this, and even outside of ICU, it's happening just in this healthcare landscape right now.
The nursing situation is such that we really can't compete with a lot of these larger hospitals that are recruiting our nurses already. I was jokingly chiding one of our nurses who announced that she was leaving, and then she told me what she was getting from this new position, which was room and board and twice the salary that she's getting now, and a block schedule that fits her needs 100%. She basically got anything and everything she asked for. How can we compete with that? How could anyone? So this is a big reason why we're losing nurses all over the system, because we just can't compete. The traveling companies that hire nurses to send them to different facilities, they're paying those nurses more than the physicians are making. And so, that's also not a sustainable model. We need to build our nursing staff from the ground up, and that's really got to be something that we're going to be thinking about. How do we start from the very beginning?
I think we all understand that it's a national problem.
Yes.
But it doesn't seem to me that the answer for Sharon is to close one of the important feeding areas for our world. I think you made the wrong decision and you continue, you're very well versed at giving us the answers, but I don't think that they're good answers. I think there are other methods that you might try, you might explore, in closing the one thing that will provide patients for years to come.
Sure. One of the sobering statistics we learned when we were looking at, we looked at 6 models of what we were going to do in the hospital when we started about a year ago. And the sobering statistic was that locally, greater than 40% of our women of childbearing age who are pregnant are actually traveling farther from where they live to Sharon to another facility. And they're bypassing Sharon and our competition to go to other hospitals. Greater than 40%. And this was before COVID-19 hit. This was before all of this. So automatically in this area, the statistic that we need to know is that having an open unit hasn't prevented people or brought people to the area, and closing the unit won't do the opposite. Because already people have made the decision to go over to other places.
Well, I wonder whether that statistic would hold for the pre-ESSENT days from Sharon Hospital.
And that's before anything. This is 2021, it's going to 2022. We have to go where we are today. So that's
and I will put my services and offer birth to a wider area.
A lot of that has to do with the fact that that shut down even 3 years ago. People said, we're not going to still have opportunities open here. You're supposed to be marketing after that fiasco as well. And there's been very little, if any, marketing those services. Got the 5-star rating, except that people get a sign on the door. The community in the surrounding areas are not aware of that.
the system does cyclical.
I'm sure you can. In fact, more person can really try to. That's the reason why you don't do it, you want to go elsewhere.
Again, as we as a system grow, the system's been using cyclical marketing from multiple services throughout all the hospitals, and they do it on a rotating basis in regards to the marketing. The marketing that people are used to seeing in the days of billboards and all that is not what marketing is today. It's digital, and it actually has been fruitful for all of us over the last few years. So it is working. So yes.
So, to me, if you say you have cyclical marketing, that means that cyclically you don't have marketing. Because if you're really pushing it out and you have ads in the paper, I do not understand how a 5-star rated OB unit cannot attract that extra 40%. Where are they going? We know that people from Pine Plains are going out to Rhinebeck. Why aren't they coming here instead? There was a problem recruiting an OB physician for the practice, and Dr. Mortman and Dr. Jaffe hired somebody about 3 weeks ago, so they're fully staffed. They were able to recruit. You were not able to recruit. And going back to the common a little bit, it's not just the part about labor and delivery I'm interested in, it's the financial projections that you made and promised when the merger happened, that Sharon Hospital would show a profit of $1 million in 2022. So I'm a little unclear about what went wrong. What is the explanation for how $1 million profit that was projected and all these rosy projections during the merger turned into a $39 million loss over 3 years? And I'd also like to know what 3 years that $39 million came in. Are you talking about 2019, 2020, 2021? Because the last financial reporting in the 990 was for 2019, showed a loss of $5.6 million. And 2018 showed a loss of $500,000. So somehow Newdance has managed to increase your losses. And I understand that you're saying that labor and maternity runs at a deficit, and I think you said at one point it was $5 million a year. And you lost $20 to $21 million. But where was the other $15 or $16 million? And why aren't we looking at that?
Yes. So thank you for those questions. And we're all along the same track. We looked at our financial status both internally, externally with 2 outside auditors over the last few years as a system, as we merged, we had to make sure that all the data for the merger actually all jive. And then we actually then brought in a third party, Stroudwater consultants, to actually look at our numbers also. And pretty much everything fits together with the story that we're telling today. And that's where we stand. Now, regarding what occurred before us, I don't know, because we weren't here when all the healthy projections were made in 2018, 2017, when the hospital was being looked at for purchase and afterwards. But we do know that after the hospital was purchased, there was much infrastructure needed to be put in, including the overhead expenditures, the allocation for the CIFR, for the EMR, for the electronic record, upgrading, just basics of the hospital, etc., led to the point where all those allocations couldn't be foisted on or put on other hospitals. They actually had to be borne by Sharon. And that's where the loss comes in, as you look at it, because the expenditures and overhead continue to rise and revenue remains flat. And that's kind of where we've been for the last 2.5, 3 years.
You said you're supposed to improve contracting for supplies and drugs and saving opportunities for purchase, service arrangements, audit, and legal fees, and all these synergies. And yet, somehow, it hasn't worked out. And I'm wondering, were you're saying states doing the projections themselves or in the execution of it? I'm not quite sure.
Again, the hospital was purchased by HealthQuest in 2018, when that purchase occurred. And and we merged as just 2 years ago, in 2019, as New Vents, and that's Western Connecticut side. So essentially, the HealthQuest team that actually had done all the projections, all that, there's not many people left on that health system. The Connecticut side of the merger is New Vents today, as we said through this. So as we've gone through all this, the numbers, we actually had to make sure that all those projections were worthy and what's the numbers where we stand. And that's why we brought in and had those audits done that should show from 990s and everything, because we had to go through all these areas as we were being looked at for bond ratings. And that actually shows you where the bottom line is today. So, and that's the issue. It's overhead expenditure, it's building infrastructure, and staffing, salaries, and just the benefits that are there, with essentially flat to slightly declining revenue. Now throw in COVID in early 2020, everything's gone off. So in 2020, I'm confident everybody lost money in that year. In 2021, we actually rebounded, but we still projected in this year about a 19 to 20 million loss. And actually, we're at projection, a little bit ahead actually. But that fits because the overhead is such based upon the economic environment we live in today. That's what staffing costs and where we need to be. And we had flat revenue. We really had flat volumes all throughout. So something has to give at that point. And that's the reality of where we are today.
Maybe better projections here for our hospital. It would be nice to have more transparency so we can see what those numbers are. I know the mutual council is going on a hospital wanted to see where the 5 million came from, where the $15 million was coming from. So we can have some input and understand exactly where that money is. I think that's
well, we did that, and then some of the data that was in the Stroudwater report actually will come out, and we can actually show all that once the full certificate of need is actually brought in, as we were asked about getting the certificate of need out. All those financials have to be out, and at the same time, when we have to give our annual report, that's when all that data for the last year then is reported. So that's why at this point, I can't give the exact all that proprietary information. Just like in any other private company who is not for profit, is going to show you to the following year when they do your annual report. So that's where we worked with our. That's what I'm going to talk about our audits that we've had, and to various work groups that we've had, along with the consultants that have come through. They've all looked at the data because they all had equal access to the data. data, and they all came to the same results. So it's not like we would be surprised, or I would have been hopeful that maybe we made a mistake in looking at the projections when we were going through our projections for what we wanted to do with transformation. And that's one of the reasons why you bring in outside people to look at it, are we sure this is where it is. And across the board, the numbers were all accurate. So it's hard to argue against multiple audits. So I'll show you the same
You
thing.
say all Child Development is available here this year for ACLN?
Excuse me?
All of the Child
The data that will be available is the data that is required by the terms of the CON. So I don't know all the data that will be released for that. I know they're working on that now. That's why it takes, from the time we announce it, we have 90 days, to actually get the CON in. Because there's a lot of other data that the state demands that you have to submit to get there. And it's not just our hospital, it's actually our system that's the supply of information. So everything has to be looked at in the system.
I think the report is, I'm just hard to understand. It's nice to see exactly how it moves on the drive.
Understand? Yes.
Hey, yes, I have a question. We actually moved here like a year and a half ago, and we moved here and wanted to a little rural area. Something that wasn't on our list was to be close to the hospital. And I'm kind of new to this, and I'm just like looking through the PowerPoint as you're talking, and it just seems to me in this PowerPoint that much of the hospital is going to become something else. That is like, it's psychiatric, behavioral health, and kind of like a big medical arts building. At what point does it stop being a real hospital? That's part one. And part two is honestly like, let's put all the Great Resignation stuff aside and like think beyond that. Everybody's happy this all across the country now, right? So but let's assume our country thinks beyond this. What does the emergency department look like 5 years down the road? Like, are we going to have to go somewhere else when there's a medical emergency? What does that look like?
No, that's the one thing I wanted to actually make clear tonight. We are not adjusting or changing any access to emergency services. If anything, we expect the emergency room access and emergency room to expand over the next years because of the way the plan is set up.
24 hours a day.
24, we're not changing it. It's always 24/7. It never was stated that we were going to change that. So we were trying to figure out where that came from, but it will always be 24/7 based upon the plans that we have all set up. Now, going at healthcare today, this hospital was designed 100 years ago when the basic model of care was you bring somebody from the outside to the emergency room, they get evaluated, they get admitted, they get treated, they go home. The model of care currently, which has been evolving over the last 25 years, is 75% of all care is outpatient. 75%. Our model of care is dated based upon the way we've been using the hospital over the last years. So we have to fit the model that actually is being mandated by insurance companies. So people are being told not to go to the emergency room. So we have to have that availability and for certain non-critical items that they actually go to their family doctors or to, they have urgent care centers throughout. So that was something that we have to look at. Second, we have a hospital that has all these empty units of beds. When it was built, it probably go 150, 160 beds. Right now, we're licensed for 79 or 78. So if we look at that, we have all this space, so we might as well use it to our ability. And we have a large inpatient unit of care that is for medical surgical, and we have a separate area where the ICU is. The ICU has 10 beds, and its average census at any moment over the last 4 years is about 2. Not 20, but 2. So that's been our issue. And it's now we have an older ICU. We have limited utilization of the ICU, and our patients that go into the ICU are actually of the case mix or their severity of the illness is much less compared to what we see in ICUs throughout the remaining parts of the United States. So to fit the rural model, which is what Stroudwater helped us to also look at too, was by having acuity adaptable beds, by having a monitored unit with your medical surgical unit, we can actually have all the patients cohorted in one area where we can flex the severity of care up or down based upon the diagnosis of the patient. So you can actually staff this better. We'll have better care because we have more support in one area instead of having them separated in 2 units, one whole floor apart. And we'll be having them all condensed in 1 unit. We have a 30-bed unit, which is only at most being used half the time. So this is a great opportunity for us to do what the majority of other rural hospitals in the United States have done, which is to combine these units. And that's what we're doing. So that's one area. So that leaves us space next to our emergency room. So this is where we would like to put in clinics for urgent care, for geriatrics, for all those other services that we were talking about in the past, for working with the FQHC, having a clinic right there, ready to go. We have a very large site unit upstairs, so we'd like to expand. We've already expanded it once, and it's busy. So having this other possible clinic, that's another opportunity for us to expand in areas that our people are utilizing here. And then the rest of the facility, again, will actually be better use of office space, better use of clinic space if we need it. And then we have a very new or an older expanded lab with new equipment that is coming online here in January. So we're excited about that opportunity of having that come online where we can work with the private offices and offer services to those people. Where in the past, even when HealthQuest was created, it was decided by HealthQuest to move the lab services more centrally to one of the other facilities. We want to share that again. So that's the retooling that we're talking about. And then since Wi-Fi has been so spotty and we don't see any short-term solution to that area, we have offered to become a hotspot for that area by having people, if they need to really see their doctor, but their doctor is going to be virtual, you have them come into the hospital, have their testing, have their x-rays, then they can have their visit with their physician through telemedicine and go over those results. So actually, get it all done at the same time, using the facility as we can. And as we expand primary care services over the next few years, we then can grow in a very deliberate fashion throughout the region based upon where the people are needed and have people rotated through those areas. So this is the plan of the hospital, which actually fits the model where we need to go. It keeps our hospital as a regional healthcare facility for all 30 communities, and it allows us to expand services with time as we grow. So that's kind of what we're looking at. So hopefully.
If there are no children being born here, eventually, isn't just this whole system going to age out?
Well, it's,
I mean, I see health care for adults over 65 in here, and talking about telemedicine with your doctor someplace else, and eventually there are going to be a lot of people who will not move here because they can't find a pediatrician, or and then daycare centers will close, or nursery schools will close, and enrollment at the school will go down to 4. Not just the ICU. So I'm looking at the bigger picture, the nuances. Obviously, I hear a lot of words about audit, finances, and whatever, and it sounds like I'm listening to an insurance customer service call. But is $5 million a year how much the labor delivery costs?
That's how much it's losing.
It's losing. So if we're breaking even, would this conversation be had?
No, because we're still, again, the hospital could not simply sustain the way it's configured at present. Change has to be made.
Change would have to be made.
We even looked at options of do we remove all of inpatient services? Or do we make it a totally outpatient facility? Or do we get rid of, just make it, as you mentioned, a large ambulatory outpatient facility with no inpatient services at all? But we found, based upon this hospital being part of a larger health system, that the worth of this facility is much to everybody in the area and to the system itself, because we, on average, today, that we send anywhere between 275 and 300 people a year to a tertiary center that come through our emergency room right now. And that's standard practice. And actually, it's one of the more efficient services that Stroudwater noted in their review. They're one of the number one rural healthcare consultants in America. And they said, we do something very well. We're very good. Our doctors are very good at triaging and understanding the people that come through the door. And based upon that diagnosis, how well can we care for the ones that we decide to keep, and how well do we care for the ones that go out? And right now, we have top decile care for all of that, and less recurrence, less people coming back for readmission than we would have thought based upon the way that is. So a long answer is that the people here will get the care that they need, and they still will come back and need that care. And that's what other hospitals have done in the past. And recently, if you look online, check out Columbia Memorial Hospital in New York. Check out New Milford Hospital, which is in our system. Check out Messina Hospital in Long Island, where they have the same problems we have, where they're short. Wingate that's going through that now, where you have to phase out the delivery services. What have those facilities done? They had a set plan like this, gave notice, had agreements with the local facilities of whether the people would be where they would have deliveries in the future, and then they grew their other services, and now they actually have done a very good job. And the fear of people having unwarranted complications, the fear of having a horrible issue, you can never 100% eliminate that, but they've been able to aggregate that by having proper communication, and that's why we're here today. And that's worked very well. We're looking at up to a 10% growth in people 65 and older. It's even higher for 55 and older over the next 10 years, and about a 4% drop in women of childbearing age and less. Now that may say, oh, you're 10% up and 4% down, but that 4% is a larger population, so it's even a bigger drop than you think. And Litchfield County right now has the largest drop in population per this last census. And it doesn't, the projections don't look any rosier. Even though people are coming from New York, for us to maintain the services, particularly labor delivery, we would have to see more than doubling, almost tripling of the population to gain that market share of people that come in to keep that service going. That's the issue.
I just want to add one thing. So our emergency department sees about 14,000 patients per year, and our inpatient medical unit admits about 1,700 patients a year. I could be off a small percentage of those, right? Those services are not changing. The inpatient service, the emergency department service, what we do now. It's true that many things that were typically a 2 or 3 day hospitalization are becoming an overnight stay or even outpatient. That changes the dynamics. But the urgent and emergent care and the acute care hospitalizations for medical patients, that's not changing.
Okay, can I just agree? It certainly sounds like nuances and has made up their mind. So I appreciate the conversation, but it just sounds kind of like watching a handful go back and forth on the wall. But what's the process? So is this a done deal? Like, you have to get this approved by the state, and how does that work? And is there a chance that the state says, nah, I don't think so? And then what's your plan B?
Well, that's the thing. Yes, so we have to then we make this announcement, and then we actually file for the certificate of need to change the service, to change the agreement that was made years ago. And if they, we'll get a case, we have to actually, we'll have a public hearing, and then we have to give our case, and then they actually spend time deliberating and make a decision. And
Who makes the case for the other side?
The community decides. It's the community having representation. So
When does that happen?
Once the process comes out, then we go forward with, they actually will tell us what the timeline is. But I know they're close to a year behind me looking at cases that were brought to them 8 months ago. So it's going to be a process. And, we are at that point where it's going to be difficult for us to maintain that service based upon, we know we have to make the announcement because we're having difficulty keeping that service going now based upon our staffing. So we have to be careful there. Now, if they rule that, oh, you must keep it, it's going to be difficult for us to say, how can we do that? We have no capability of doing that. There's other hospitals in the state that have gone through that where they've actually had to unilaterally shut down their service, and then they waited 2 months, and then they filed the CON. And they're just finally getting to that point. What's going to happen? It'd be interesting if the state makes them stay open. I don't know. But there's a limit to how, what you can and can't do. And that's why it's up to our part to hear everybody out, explain, giving us, we'll give our reasons why we think we need to go in this direction. The state's going to have to, let's agree or disagree with us. And then we'll let the system work with the state if there is a disagreement in the long run.
So nuance isn't changing its mind.
So,
So nuance is not going to be taking some information back and kind of saying, oh, maybe we can do a little bit here, a little bit there. This is sort of like, this is my plan.
and as I mentioned earlier, prior to COVID, if we were not part of this health system, the hospital would have been closed. So it's that close. That's our issue, yes.
Dr. Burke, might be helpful to these folks since they're new in the community to explain the different labor and delivery models you also looked at.
Yeah, I mean, we looked at lay-first models, we looked at models where we had full-time OBs with the laborers in the house, we looked at nurse practitioner models, we looked at midwife models, we brought in OBs from outside areas to work here, and then we actually recruited 2 people actually into this area, and then they lasted about a year, because they're about the way that everything worked out, they felt safer going back to their own practices. So we did bring 2 people on board in the years that we were recruiting. So it's been difficult to maintain that service, and it hasn't changed.
So my son and his wife are actually having their first baby next month, and they live over near Hudson. So my daughter-in-law started going to the Columbia Memorial practice there, and was so incredibly unhappy. She felt like she was like taking an unwrapped bakery for her plan that she was not interested in going up to Albany to have her baby delivered. So she, at like 4 months in, said, I can't do this to myself anymore. She bailed, and she's now going to all her visits, all her sonograms, everything else, going over to Fairview over in Great Barrington. So I'm curious, and she, according to her, she's on Facebook groups and everything, it's like the model over at Columbia Memorial from young women where they're having babies and get like a big. So I'm concerned that that's become like, that's what's going to be good, because according to the young mothers going over there, it's not really very good. So I'm curious what you have to say about that. And also, just how's Fairview doing? Like, what are their numbers looking like? She said they're going there, they're going up to Troy, they're spreading out.
Yeah,
Geez, they could have gone to Sharon, it seems to me.
That's what I mean. So you're going over there, but no, a lot of hospitals, we're going through this transition in rural health. Fairview has picked up some, and they have an edge here. You have Barrington, you have Charlotte Hungerford has picked up some, and then we had a certain number here too. So everybody's doing a little bit of everything. Rhinebeck has actually been the biggest winner in the long run. These are very busy, and it's not going away. It's actually growing. Now, there was another issue that you brought up about labor and delivery is changing too than it did years ago. Anybody who has had any risk is multiple, possible twins, any prior complication like that, they are considered moderate to high risk already by maternal fetal medicine, and they tend to actually have to go where there's a NICU. And that's why a large health system that has a NICU is very important for those people. So if you look at even us here, we're only taking the best of the best in regards to being able to deliver. And that's why it's going to be hard to grow that number even anymore, because anybody with any risk or anything have to actually go to those other areas for the possibility of a problem in the future.
But
So
since the
that's
Fairview model is working, right? It seems to be attracting, and they're doing a lot of work with the midwives and
that
want to have
reductions.
Fairview?
Oh, Fairview?
Fairview, are you referring to Fairview in Great Barrington?
Yeah.
Yes, Fairview is a critical access
It's
hospital.
access.
So their reimbursement, their funding is very different. And we actually did look to see if Sharon Hospital was eligible to be a critical access hospital, and we're not. There's certain criteria, and I can't remember it all, but it's, how far are you from other hospitals, and about the roads that you travel and whatnot, so we weren't eligible. But if we had been, that would be a major consideration in our plan.
What what changes in legislation would be required to make Sharon Hospital a critical access facility?
There's multiple areas. Most of it is actually looking at the rural road miles. The rural, what is the access to your hospital from another hospital? They look at the road.
Sharon Hospital is just about as far away from any other hospital.
We're too close to Fairview. We're too close to Charlotte Hungerford. We're too close to. We're actually too close to everybody. And that's why we had Stroudwater come and look at us. They thought for sure we'd be granted that access, and we were completely denied. And they had the roads looked at so many times that they actually told us exactly where we were, and we would literally have to sabotage a lot of these roads to make them, they're too well developed, and therefore we can't qualify for them.
Is that a state mandate or a federal mandate? Federal.
It also has to do with how close we are to another critical access hospital.
Right. And we're too close. So we're isolated, but we're too close to other hospitals. And that's why we brought in the top rural expert to look at us. And they tried everything we tried. The same questions you asked, we would ask. And the answer came out the same way.
I remember the Sharon Hospital group, and we looked into that as well. Connecticut is one of the 5 or 6 states in the country that does not have critical access legislation. So that's
I'm sorry.
Connecticut doesn't have critical access legislation.
Okay.
So that would have to be changed. For about 2 miles close to Fairview. The question of road going east or west, and different roads going north and south.
Of course.
So I think that can be explored more detail. That's one of the things that we're looking into. And but I in the past, it's something that should be looked into.
Is it something like we missed it by just as
Miles,
much?
there's miles, there's elevation changes, there's other natural obstacles, all of that is taken into account as they go for that. Now, we do have a rural access hospital, and we maintain that designation. So we do have some increased reimbursement based upon that designation. We've had that for the last 3 years now. We have to reapply for that every year. That's one of the reasons why it's very good for us to keep our inpatient units open, because that actually does help us. But we really have some serious trouble. Better to gain that designation.
And how much time is left on your certificate of need? When did it begin and when is it set to expire as it exists now? A year and a half is which?
Well, we have a year and a half before this current certificate of need that mandated that we do use all manner possible to keep our services as is at the time of purchase and or merger under commercially reasonable.
1.5 years left in your current term of your certificate of need. Okay.
Yes.
Thank you.
Because it was a 5-year, that's why we actually have our community forum coming up here at the beginning of December to go over that certificate of need and how we stand in regards to compliance. Because the state gave us, or they mandated an outside auditor, which comes in twice a year, and they go over all of the terms that we have, and then they report to the state if we're compliant or not, and then they let us know. We have no say in that. And then they present how we're doing, and they present what they found.
And what was the last period that Sharon Hospital was in the black?
2017, right at the time of purchase, or right when it was SM.
So,
Right when it went to SM, we went to here. So it was that first year of purchase, right in that 6 month.
and what happened after purchase that made suddenly a hotel that was in the black go into the red?
What we did is as we looked at a deep dive over the years since then, there's a thing called an allocation in regards to you have to account for your overhead. And it appears that after the purchase had occurred, a lot of Sharon's overhead was being borne by Vassar Brothers Medical Center for the first year or so of the system was purchased. And,
That was after New Vance purchase.
no, not New Vance, HealthQuest.
I'm sorry, so 2017 was the last year before Sharon joined in with this larger system?
Yeah, because Sharon was part of Essence/Regional Care. Okay? And then in the mid-2017 was purchased, and then that first year went up through mid-2018. And that's where we showed a profit, $1 million profit. But then, and then from then on, then all the overhead that was being borne by the other hospitals had to be appropriately designated to Sharon Hospital. And then we had the merger with the Western Connecticut, just to show that. And that's when you see what the true nature of the hospital, or what our finances were, based upon that overhead that wasn't there. Look, I wasn't part of the purchase, and none of us were there. This is where we are, and then we saw that. And then from then on, the revenue, was kind of like this, and then you saw that the expenses were.
So, but it sounds like the really great number crunchers and New Vance were kind of taken in by whatever accounting issues, or however it didn't understand what you were buying, or
I wasn't there, and I don't.
Of course not you, sir.
No, but the people.
But by putting all this off onto a third party or some other person who's not in the room, that leaves no one with any ability to give an answer or to understand an answer. And it sounds like kind of pushing the buck and kind of a bunch of, well, I wasn't there. I don't know. That means the community holding the bag, sir.
Understand. And here's where Ron gave the answer that there was a reason, as I mentioned earlier, there was a reason why there's been 4 owners in the previous 12 years. It's usually not that the hospital's making lots of money. Okay? And that's kind of the bottom line.
And so New Vance kind of swooped in, being the very clever managers that you are, I assume, swooped in with the thought that you guys might just hollow out the hospital and take what's here and suck it into some other parts of your system and not provide for the local community?
No, I think, again, what we're trying to do as a health system is to be integrated. You can't have 7 hospitals doing seven different things. So to be part of a larger health system, each hospital has to be an active cog with integrated services. Being 2 years into this, we're barely to that point where we develop service lines we're starting to integrate. On top of that, each hospital will serve its purpose as we go through there. We have found where the strengths are. Each hospital has its strengths and weaknesses. And the strength of this hospital is we need to have a viable, sustainable healthcare center for the 30 communities in this area, both in New York and Connecticut. And by doing that, we have to be able to recognize what we can care for and can't care for. And that's what we do very well. And then while we do that, we at the same time look at growing services that are necessary in recruiting doctors, hopefully recruiting doctors that actually can care for that and utilize the strengths of that larger health system. And we have to parlay the technology early on until we are able to create an improved critical end of doctors that actually can start rotating through the various areas. Because it's too expensive to have 4 neurologists here, 4 oncologists, and you just can't do that. There's not enough volume for all those doctors, for the doctors, so therefore you have to have the ability to rotate those people through. And we are very early in the process of the system in creating those service lines. And that's the tough nut we're cracking right now as a health system. We're still new. And we are busy growing all of those service lines. And that's what this project is about, is growing those areas. And what do we do in that transition when we do that? And it's painful. And we're running through that right now.
Right. And Sharon's position in New Vance geographically is logical, right? Because we have the New York side and we have the Western Connecticut side, and Sharon's right in the center. And so it wouldn't make sense for Sharon to be part of a different group because of the geography.
But it still makes sense that Sharon being the center of this group, that Sharon's services should be scattered, even though we are the geographical center of the group.
Should be
Scattered.
You know, what Sharon is it's a small rural hospital between very large tertiary care centers who can offer the full gamut of care. And Sharon, finds its niche in caring for the basic needs of our families and specialty needs based upon the specialties we did here, and handling the diagnostics and the post-care for a lot of the patients, including physical therapy, occupational therapy, stuff like that. That's what a rural hospital does, and has the lab services. And that's the services that we're looking to grow and build through here, because we have the tertiary care and expanded services in other facilities, and we bring people back. That's how the system integrates and works through.
And I think that you said in the meeting on Friday that lab services will be returning to Sharon, or a portion of lab services.
We've partnered with Sonic/Sunrise. Who actually helped us during the COVID crisis when there were shortages. They actually had supplies that helped for the rapid testing we went through. And so working with them, we're going to be integrating a lot of their services and their expertise to actually help us with our offices. This was planned actually to be rolled out much earlier, but because of, again, the shortages that are occurring throughout the nation, there are shortages of blood draw tubes, the tourniquets, the needles, the syringes, so all that stuff had to be backed down. That's why we throttled back to it looks like January before we can implement a lot of those changes. But we're excited that we can say, hey, we're bringing something back. We saw what was done before. We want to show that we're helping the community again.
And I'm sorry, you mentioned before, and I didn't understand or didn't hear, which lab services will be returning to Sharon Hospital?
I don't know all of the lab services per se, and we're hoping basic lab services for sure. I don't know what the specialty services will be that, because again, usually you have to pull some of those very, very rare specialties together to run them in an economical way. So,
Yeah, I just want to clarify. I don't know the specifics, but what we provide from the customer perspective is you can come to Sharon Hospital and we can obtain basically any specimen that is ordered. It's the processing that's different behind the scenes. So sometimes we have to send stuff out to another center. And really, because the volume of those specialty tests is so low, the cost of having the equipment and the resources to do that, it makes more sense when you bunch them together and you do them at a center that has more of those tests. I'm just trying to help explain what goes on behind the scenes. But from a customer perspective, Sharon does all of the collections, whether it be blood draws or urine specimens and other specimen collections.
right, and a lot of that testing is done at Sharon. Sharon didn't close the lab. The lab is up and running, and we use it every day. It's just some of the testing is
I guess that if you're trying to tout that lab services will be returning to Sharon, and you don't know which services will be returning to Sharon, and saying that it makes more sense to group and bunch lab services to some other place, you're saying a whole bunch of things that go around in a circle for people like myself who perhaps don't understand as well as yourselves what you're talking about. Because you're saying this and then you're saying that.
here's where the issue is. A lot of the private doctors and non-affiliated doctors that work at Sharon Hospital need centralized lab services, and they want communication with that. When HealthQuest purchased the hospital, the decision was made that that center of that lab would actually be in New York site, because New York purchased Sharon. And so they did that, but there were delays in getting the results back. And there were delays in ways of integrating the labs to be seen on the electronic medical records of those doctors. So by having this other group work with us, we're working on them helping establish that throughput, so when the labs are drawn, they may be done elsewhere with their lab services, but they're helping with the technology so you can actually get the turnaround time much sooner than you did before. I.e., instead of mailing it or faxing it, you get it now as soon as it's run and done and it's on the computer. And there's an interface that allows that. That's what they're offering in regards to the service to help us go through. And that's why what labs are and aren't going to be done is probably going to change on a monthly or quarterly basis based upon the need that they have. That's the part that I don't know the lab, I don't know. But that's the logistics of how we envision how that's going to work out, which is a marked difference than what occurs today. So, yes.
I promised my wife I wouldn't say anything, but I have to. You look at the population from 1974 until yesterday of the birth rate, it hasn't changed. The birth rate is on average 30 to 40 patients a month. From 74 until 80, there were only 2 obstetricians working here. And we delivered all of those patients. Trying to get a patient to go from Canaan, Salisbury, Goshen, Lakeville, to go over the hill in Millbrook, to go to Poughkeepsie, is a danger, a real life danger. You're going to kill somebody, either in an accident or the mother's not going to make it there. Of your trustees, there are 3 that I know personally that participated here. One was a nurse, and she's in Millbrook, and the other one was a pediatrician here in Sharon. And then, of course, you got the CEO of the bank. None of them are speaking against this move. The other individuals you have as trustees are from outside the area. They're not even close to it. They come here for the weekend. That's not what's working. The problem is if you have a patient in labor and she is first babysitter, starts labor, goes over the Dealenburg Hill into Millbrook, she still has another 30 miles to go before she reaches a unit in Poughkeepsie. It's a danger. You're going to see deaths, and you're going to see a tremendous number of accidents. I am not practicing any longer, but I feel for the women in the area. It's not the right thing to do. OB never really made any money over the years. If you look at the birth rate, 74, 84, 94, it never changed. It's around 30 to 40 deliveries a month. It's never changed. So it's not going to change. But you're going to cause an accident. Not you personally, but your group. It's going to cause an accident and possibly a death going over there in the winter. I think it's a wrong move. If anything, if you left OB here, it will attract relatives of other people to come here. And that's what it did when we practiced. In other words, a mother or an aunt said, "Where did you deliver?" "Oh, Sharon." "Oh, do they have any doctors that I know?" "No, but I can introduce you to somebody." And they came here and they were seen and taken care of. I said this the other day, and I'm sorry I'm saying it again. It's not your fault, and it's not his fault or her fault, but whoever is making the rules are not considering the patient. And that's what you have to consider, the patient. And in this case, you have 2 patients. You have the mother and the baby. And it's a big mistake, and you're going to have the largest lawsuit you've ever seen if somebody gets in a bad way. I'm sorry, I had to say it again.
Dr. 20 after.
We've had a doctors group who used to group the hospital for several months trying to change their plans. It's futile. And we had a meeting with the medical staff. The medical staff doctors were out there defense, the doctors were worried about repercussions. They were 25 to 1 against their plans. I've had patients that go to the ER. It's nice to transfer, but I have people that are treated in the ER that are not treated properly. We don't have a T guy here anymore. All right? We lost our neurologists. That's a crucial thing. They have teleradiology, but it's not the same. You've got to touch the patient, talk to the patient, be with the patient. And they're sacrificing that with the teleradiology, mobile doctors. So it's not the same method. In a small rural hospital in the country, in the wintertime, it's not going to work. That's a big problem. The other thing is, additional point here, they didn't look at the proper financing. They've got a preset motion. Total, you save the money as quickly as possible. What about philanthropy? You know how many billionaires around here? You think they think they're in their pocket? If you want, say, every $5 million you're stable me, we went that, no trouble. No. What about having communities finance the hospital? Responsible to trust them. So on a per capita basis, you got to contribute to the gig. What about that possibility? That never pursued? No. Their option is just cut. I've been there for 40 years. And since we become commercial, more and more things have been cut. We have 4 oncologists here. Now, we promised in 5 years. Now. So they make all these promises, and nothing happens. It's easy to make promises. Don't worry about the bottom line. And it's unfortunate for people up here. Got to try to stop this.
So I guess my question, or talk a lot about the, excuse me, whatever. Thanks. Talk about the system, and the system has to integrate it. So there's a lot of conversation about nuance and what they need to do. And honestly, I hear very little. You talk about the rural hospital, but not a lot of conversation about the local communities. You kind of have this macro level that the system can deliver all this stuff, and they're not having redundancies. But if your plan goes through, and in 5 years, where are all the pediatricians going to be? Are they going to be still here, or some of them, or are they all going to be focused around these now centers that you've created? So if someone does choose to have a kid here, or raise a kid here, are they now driving 40 miles to get to the nearest pediatrician, or a dermatologist, or, you kind of like turning your centers into specialty areas, like orthopedics or something, and I don't know, it just seems like you're just dispersing, sending people all over the place.
Very, very legitimate concerns that you have. It's been difficult to even maintain pediatrics in this region. Very difficult. And that was one of the more unstable issues that we've had in maintaining our labor and delivery unit. Has been having stable pediatricians in the area. Actually, we had to get from another area to come over here to help us out. So that's been something that, that along with the ROVs, which had some issue over the 3 or 4 years, and our clinical staff. That's the tripod that's necessary to keep that unit going. And all 3 of those have been unstable in the time that this facility has been purchased and has been very unstable. And it's still something that every day we look at and look at a month ahead of time to make sure there's enough coverage for all these issues. I don't see that changing anytime soon. So in the future, I can't predict where we go. But we want to actually be, we want to be good stewards of the community, work with the community. A lot of our hospital leadership and the other hospitals in our system are very strong with working with economic development councils and stuff like that. We'd be glad to work with people there to help be part of that economic driver to help people come to the community. So we'd be glad to partner with people if the community decides to develop that and go forward with it. Regarding the other subspecialties and all that, I know the system would love to have dermatologists. Very difficult to get to work within the health system. And we as a system, in a lot of the areas, that, rheumatology, etc., are very in short need. We talked about the aging population, geriatrics. They anticipate over about 100,000 needed here in the next 10 years. There's only 20,000 total. So we started a fellowship just in that. So we decided, since we can't recruit here, or it's difficult to recruit, we might as well grow our own. And with the hopes that we've done a good enough job with training them and showing them the area that some of them will stay. That's our promise, that we're trying to use that. So you can see we're going in multiple areas, trying to grow a stable workforce that will stay here in the long run.
Or does nuance, if you don't have coverage in the area, because you talk about the system, will a doctor recommend a doctor outside of the system just because they're close?
If they have to, yes. And you'll hear that the doctors, oh boy, during the mandate, we have to keep everybody in the system. We don't have all the specialties in the system. But some people are affiliated, even though they're not in the system, but they're close. And by that reality, of course you have to stay in the area. And we do that. And some people, we know that some of our employed doctors are incentivized, as a bonus to actually keep people in the system, because that allows us to get revenue in the system and allows higher-end specialists to be recruited in the system. So you see, it's a fine line of how we do it. In a rural community, it's a little bit more difficult because, again, not that many high-end specialists or well-rounded specialists are there to fill all the needs of what a community would want. That's why it's best to be affiliated with a larger health system that can offer those areas. Instead of, by tradition, people being here and going into Hartford, or people going to New York City, or going to Indiana. That's where people are keeping them close. But it's better to go to Danbury than it is to go to Poughkeepsie. And it may be easier to go to those areas than to go all the way to those larger metropolitan areas. That's what we're trying to show, and that's what we're trying to do.
I want to elaborate and just kind of further explain, what we're doing, and I want to elaborate on something that Dr. Kirsch mentioned. You mentioned that we lost one of our one neurologist that we had in the community retired recently, and since then we have supplemented with teleneurology, so being able to consult with a neurologist via a computer screen. They have access to our medical record and access to our clinicians on site. We are a certified stroke center. We just received the Silver Plus Award for stroke. And what that means is, for all of the patients that come in with a stroke, we provide top-notch standard of care. And that's consistent with national standards. So just because it's different doesn't mean it's not good medicine. And medicine is changing across the nation, and we have to adapt to that. And change is hard, but it doesn't mean that it's not good care that we're giving. And I just want to emphasize that, because there's a lot of change, and we have to use different, innovative ways to deliver care in the community.
And then finally, just to follow up on that too, CMS, who is Medicare, Medicaid, the ones that sponsor, they pay the money to those services and then cover the majority of reimbursement for a lot of healthcare in the U.S. So we get rated, every hospital gets rated by CMS yearly on their safety, on the quality of care, and a full gamut of issues that we have no control over. It's data that actually they pull from all of our reporting data, and then they rate us on a scale from 1 star to 5 star. And we're one of the 4 hospitals in the state of Connecticut that are 5 star, and we are multi-year winners now, consecutively. So I think our staff does a wonderful job with caring for the patients that come through here, and nationally we've been recognized by these 2 entities as offering high quality care. That's what we want to offer. It's different than the care that people are used to seeing traditionally, but that's where healthcare is going. We have to be able to offer these services as best as we can here without hurting the quality of care for those patients. And we've been able to do that in these ways.
In terms of, I'm very glad that Sharon Hospital has a high rating and has a great stroke care department. What is the hospital doing about marketing that kind of information? Where have you guys been putting that information so that folks who may live as far away as, Bangkok or a bit further afield, that they would think, oh, I should go to Sharon Hospital, or whatever, and then also about stroke care. Is that about rehabilitation, or is that just kind of like stroke triage?
Acute stroke care, i.e. people come into stroking, are recognized within 30 minutes to an hour by CT, and then if they have the acute stroke that actually is mandated, that's not a bleed, they can actually receive the blockbusting medicine, which they receive here, and then if need be, they stay here if possible. If they need further intervention, then they're shipped out, and then they come back down. So that's integrated stroke care, and here, totally using remote access, we've been able to gain that national recognition. So that's where we want to go, and how we can help people keep that high caliber quality of care, where in the past we couldn't do that. So I'm encouraged by that. What was the first part of your question again?
And I guess my question how do people know about that? I guess if you're having a stroke, you're not going to stop and think, well, I should have go to like Gossip Brothers or Sharon. But is that EMTs or, who is it that gets that information? And it's great that you have this high rating, but
College.org. Our website has all that information on there. So, and that's because the majority of the people that actually seek us out, other than word of mouth and through the doctor's offices, is actually going online. That's where the majority of people look. If you look at the gamut of services you have, and they look at some of the ratings, and all that stuff is there. And the part of this is the executive summary and other recently used scholarly report is also on that website too.
And is, I guess that rating is only given upon services provided, and if services are not provided, that rating would still remain at that same level. Or is it on some like a global, more holistic series of services provided?
Well, it doesn't go by services provided, it goes by the actuality of how you've integrated those services to minimize stroke mortality, death, or stroke morbidity, which is the long-term adverse effect that the patient has, or complications. So actually, it's stroke care, because you have to recognize what you should be doing and what you shouldn't be doing. And then you take care of that patient.
Yes, there are standards that come out from professional organizations that say if you have a stroke, you need X, Y, and Z in this period of time. If you have a heart attack, you need X, Y, and Z in this period of time. And so when our patients are given the diagnosis of a stroke or a heart attack, at the end of their visit, it's coded, it's medical coding and billing, and it's sent to Medicare and Medicaid services, and then they will look at those charts and say, okay, this patient had a stroke, they had X, Y, and Z in this period of time, the hospital gets credit for that. And it would be the same if we did not give that standard of care. Our rating would be very much lower. So there's no way to kind of hide from it if you're not giving appropriate care.
And if you're not providing maternity delivery services, you're just not going to be rated on whether or not there's a 5-star or a 0-star rating, because you're just not offering that
So we won't be
service.
offering the service.
That's right.
We don't offer open heart surgery here. So, then that's so we don't rate it on that.
Okay, just one more question. I know.
Yeah, that's okay.
And this gentleman kind of brought it up. Is New Home's a nonprofit or is the hospital a nonprofit?
Everything's nonprofit.
Everything's nonprofit. Is one of the options that Stroudwater or whoever kind of looked at, is if there was an endowment for the labor delivery department that was fundraised, and someone plunked $50 million into an account and it spun off interest and we're able to fund or make that department whole, is that something that you even looked at?
I don't think we'd ever say no. We're looking at the information that's
Well, did you
issue.
look at it?
But there's a lot of
I see too.
it's more than just $5 million, but that's just that whole infrastructure is very expensive, and that's the part you have to look at. You have to have that endowment for years, 50 years, 100 years. That's literally how you have to do it. It's expensive, and not too many places in the United States that get that kind of endowment. And that's been the issue. And up until just last year, there's been zero philanthropy in this area because this was a for-profit hospital before HealthWest purchased it. So you can't have philanthropy with that because it's for-profit.
But it's not just, you can't look back at it.
And that's why we're looking forward. That's why we actually were able to, for the first time last year, our first year, we were able to give $1 million. And then we got a matching grant, or a matching challenge, and we were able to do that. So I was very happy with the community. Really worked hard in partnership with the hospital to bring those dollars in. For the first time we've seen philanthropy in years. So we're now reinvigorating that. That's why we're having these types of this type of event, and we're going to have other informational sessions with even potential donors going over the same question and answers you guys have asked us. And that's the only way we're going to be able to. We have to work, in answering the questions and going over what the philosophy is of where we're going. And it may not be what you want to hear, and at the same time, it's difficult for us because there may be some questions we can't answer. But we want to be there to have this dialogue because we have to gain trust. We have to start with trust. And that's been an issue that I've seen in my year and a half that I've been here, almost 2 years now. So that's the part that we're trying to work with.
So, but, in terms of cattle campaigns and stuff like that, slightly non-profit organization fundraising, at a much lower level.
Oh, no.
There are obviously organizations that can put together a feasibility study and say, hey, based on your finances long term, you would need this number you would need to raise this amount in order to fund and maybe partially cover the salaries and partially cover the building. I think that just seems
I
like.
mean, as a matter of fact, when we first moved in, I actually wrote out a check, not as to Sharon Hospital. Sharon Hospital has not come back to me asking for anything else, like, there's clearly not anything going on there right now.
Well, so I had a meeting with Foundation actually today, because I'm having an event Friday. And so we are finally, we're actually, we're getting traction from there. And we'll keep doing our best there for you.
Being here for 40 years, used to have numerous fundraising efforts, law, and so forth. And the hospital solved and things go after many years. Fundraising was a big part of it. And I don't know where they keep everything on.
So, just to follow up with what the gentleman said, so labor and delivery is not incompatible with the other things that you're trying to do. It's a cost thing, right? So in other words, if the problem could be solved as far as the cost, it's not taking up space you need, it's on the second floor, you don't need it for your geriatrics and everything you're talking about on the call being on the first floor. So it could still exist along with everything else that you're proposing.
It's just not cost. Because we don't want, this was not a financial, this is it's a full gamut decision based upon the future demographics too. And that's been an issue. And it's just that we see declining birth rate in this area. And the census has shown that, and yeah, there's been a blip here and there, but nothing to show sustained growth to the point where we would be able to add so many more births that we would actually have an area where it would actually be, long-term safe and financially sustained. That's what we're looking for.
But what we're talking about is if you could supplement it. We have the Sharon Audubon Society here, for instance, and there's a national Audubon, there's a state Audubon, and we raise money to supplement Sharon Audubon that stays in Sharon. So what we're asking is if we could get the birth numbers you're talking about, you have 60% that deliver in the catchment area, there's 40% that go elsewhere. If we could get those numbers to come back and bring it up to, let's say, 250, 275 births a year, then there would be a gap. And if it could be funded within the community, would it be possible? That's what I think we're asking.
I never, at this point, I just don't see that where we are today in maintaining the service, even at that level. It's very difficult at this point to maintain that. There are health systems in the United States that actually close labor delivery units if they deliver less than 1,000 births per year. So, I mean, this is the reality of what's occurring in the U.S. And regionalization of certain services is the benefit. Open heart surgery, long-term congestive heart care, high-end surgery, bariatrics care, labor and delivery. They all fit cancer, long-term cancer care with cancer surgery. And that's where the larger tertiary centers are located. We don't have that capability. And in the long run, it hasn't been very, it's difficult to maintain that service. So that's what I look at. I want to thank everyone for coming tonight, and I really appreciate those questions, and hopefully we've answered the best of our ability, everything we have. And we'll be continuing these conversations. We have the forum coming up here in December. We have another community event next week that will be out in Interlaken. See people.
What is the event next week?
It's the community roundtable, so it's the same format, a group of 15 folks. It's at the Interlaken in Lakeville.
And what's the date on that, please?
That's November 18th. from 4 to 5:30, and that's advanced registration. So we're asking folks if they have already attended a roundtable session, that they leave those seats open for those who may not have been able to attend.